As a research-based firm with the vision to be the most important dry eye and ocular surface disease company in the world, Pharma USA provides innovative OSD solutions to the American optometry and ophthalmology community. Through the years, Pharma has continuously invested heavily in R&D and has created unique and effective products for ophthalmic surgery and for the management of dry eye disease. Our mission is to bring complete relief to dry eye and ocular surface disease patients worldwide. See the difference with Pharma USA.
Well, it's 5:30, so I'm going to go ahead and get started. I'd like to first say thank you for everybody that has joined us. I am Michelle Schnabel, the Vice President of Business Development with Pharma. We're excited to be able to have Dr. Cynthia Matossian join us this evening as our expert on dry eye. Dr. Matossian is the founder of Matossian Eye Associates and is the president of the American College of Eye Surgeons, as well as the president of the New York IOL Implant Society. So we're excited to be able to have her share information on our products and technology this evening. So I'm going to turn it over to you, Dr. Matossian.
Michelle, thank you so much for that wonderful introduction. And I want to say thank you to all of you who have dialed in and have committed the next 60 minutes to spend time with me, with Pharma. And we're really going to have a wonderful interaction. I want you to use the questions button and send your questions. There's no such thing as a silly question or a funny question or a stupid question. I encourage all questions because that's really how we all learn. So use the question button and then I will do my best. I promise you that to answer them as time allows. And I'm going to answer the questions as they roll in, not wait till the end of the presentation. Big shout out and thank you to Pharma for inviting me. And we'll start right there. We all know how prevalent ocular surface diseases, dry eye disease, meibomian gland dysfunction. As you can see in this picture, the traditional postmenopausal woman is not there. And that's done on purpose. And that's because the face of dry eye is truly changing. You can see a teenager here, maybe a pre-teenager, on her cell phone. You can see an executive like squeezing his eyes with a laptop open. You can see somebody who's a contact lens wearer, an executive perhaps, somebody with red eyes, and you see an elderly man. Again, holding an e-device, a digital device. And that's what we all have in common. So the face has completely changed of dry eye because the commonality, besides advancing age and more candles on that birthday cake, is what we're doing with our eyes for many, many, many hours a day, which is screen time. Let's go to the next slide, please. So why is it important to identify, treat dry eye disease? It's not only just to improve the quality of life of our patients. These are patients who are really suffering. Their productivity at work is not what it used to be. They're taking a lot of breaks. They may even call out. There's higher absenteeism from work because of ocular surface dry eye related comorbidities. Plus, a whole other factor is for all of us who are cataract and refractive cataract surgeons is to get better surgical results. If we're measuring on a dysregulated tear film, we're going to get completely unreliable data. Even if we plug them into the best IOL calculating formula and you do flawless surgery, we may end up with a refractive surprise if the original data was too off because of an unhealthy tear film. Therefore, it's important to identify, diagnose, educate the patient that there's something going on with their eye, treat so they stay compliant with whatever you as the doctor is going to recommend to your patient, and then you have to manage them. How are they responding to your treatment regimen? Is their disease progressing? Do you have to alter it? You have to be very fluid. And with iMed's information and diagnostics, you'll be able to track exactly how well you're doing. Next slide, please. We're going to start with a three-pronged approach. That's what's unique about iMed Pharma. They have the diagnostic component, which is very extensive, and we're going to dive into that shortly. We have the treatment option through iMed, and then we have the at-home management component. With other companies, most of them are siloed or fragmented. They only diagnose or they only treat. They don't have the at-home component, or maybe that's all they have is the at-home component. With iMed, it's the entire package. So let's go to the next slide. The first thing that we're going to start with, of course, is to identify and diagnose dry eye disease. Why is this important? It's important because A, there's a disease. We are scientists, and we want to base our therapeutic options depending on what we see. Patients, to become believers, especially those who are asymptomatic, want to know their numbers, want to see their pathology. Just like, for example, high cholesterol. There are no symptoms, but it's not till we do the blood test and get the report that if it's abnormal, we know now that we may have to take an oral medication, lose weight, adjust our diet, and then track that by the consecutive tests that we get via a blood test at a lab. Well, it's kind of similar with dry eye disease. You can't just tell a patient, ma'am, sir, you have dry eye. We have to show it to them. And by showing it, you're going to make a believer out of the doubting patient, that asymptomatic patient to whom I was referring earlier. And it helps with compliance. Once they see their numbers improving, trust me, they will stay the course. Next slide, please. Sometimes when we look at algorithms, for example, this is from TFOS, DEUCE2, ASCRS has algorithms, and all these various tests and kind of diagnostic approaches are referenced. And it becomes daunting for the practitioner. Which piece of equipment do I buy? I don't have the real estate for it. I can't fit it all into my office. How am I going to move the patient from room to room to room, or chair to chair to chair to do all these things? Well, you don't have to worry about that anymore. iMed has the solution via tearcheck. This is their 9-in-1 diagnostic test. It is a desktop, small. It sits on top, literally on top of a desk. We'll see the picture of it in a moment. And it does 9 different dry eye diagnostics. Let's go to the next slide, please. This is what it looks like. It's the picture on the right. The part that says tearcheck and it's facing the screen, that is where the technician would be standing or sitting. It's a touch screen. We'll come to that, very easy to use with a laptop for communication. And this can be then integrated into your EMR, and it can be integrated via Bluetooth wirelessly to a printer, because you're going to be able to print the report in color and give it to your patients. The patient sits on the other side, and you can see that blue kind of forehead rest on that picture. The 9 diagnostics, and we're going to delve into some of them. We're going to look at eye fitness test. We're going to look at eye redness test, non-invasive breakup time, as well as tear film stability evaluation, tear meniscus height. We're going to be able to zoom to the base of the lash to look for the little collarettes, which are pathognomonic for Demodex. And we're going to look at different blinking patterns as well as meibography. So let's go to the next slide, please. And we'll start here. So this is a technician or a physician. It's touch screen, as you can see, very easy to use, and it guides you and actually prompts you to the next step, to the next step. All of these tests that are bulleted and kind of pictured on the lower right-hand corner can be done in 5 to 10 minutes. So you might say, oh my gosh, how can I extend the patient throughput by yet another 5 to 10 minutes? Realistically, it might be 7, 8, 9 to 10 minutes. Well, the concept is when you make the preliminary diagnosis of dry eye, maybe through just a vital dye test, lissamine, green, fluorescein, maybe a questionnaire, maybe just based on symptoms, you can ask the patient to come back and say, we need to do a dry eye workup. It's a scheduled appointment where the technician is the one empowered to do all of these tests. The patient knows they're coming in for a battery of dry eye tests. And at the end, you as the eye care provider will not only hand the patient the report, but based on the outcome, come up with a customized treatment plan. You can charge out of pocket if you wish for these tests, because none of these is actually covered by insurance. And patients understand that, and you don't have to charge an exorbitant price, just enough to cover the cost of the technician, your time, and the value that you are providing patients. And IMED will guide you with kind of what the norms are in Canada and in the US. Next slide, please. These are some of the diagnostics and some of those 9 tests that you can do with the one tearcheck device. You can look at the non-invasive breakup time, and I know it's hard to see, but of course on your tearcheck, the monitor is much larger, and you're going to be able to see red, green, yellow, and orange spots on the cornea, and that's going to reflect how healthy or unhealthy the tear film is. And you can show that to the patient. You're going to be able to measure meniscus height. You can see that with fluorescein there. You're going to be able to look at meibography, as you can see, and then track it over time. And what's even more amazing is that this is the only unit that I'm familiar with where it will actually give you a percentage of meibomian gland loss. All the other meibographers that I have used to date, you have to say, mild loss, moderate loss, severe loss. You're kind of putting them in buckets. This one will give you a very specific percentage. As you can see in the image there, it says 10%, which means that this person has 10% meibomian gland loss. Let's go to the next slide. And this is what the report looks like. So on the left-hand side, you see the list of the 9 different diagnostics, the 9 in 1 unit. The green, yellow, orange, and red are kind of color-coded for the patients to better understand and for you to see at a glance where they're going to end up. So each bullet contributes a piece of the puzzle. So by you at the end looking at the entire scoreboard, you're going to be able to figure out where the bigger problem areas are. Is it more meibomian gland issues? Is it more maybe, aqueous deficiency based on where you see a lot more red versus green, orange, and yellow? And accordingly, you can come up with that customized treatment plan for each and every patient. And that's what patients want these days. They don't want to be just a number in an office and be given the same exact cookie cutter approach that the person before them and the person after them is going to get. They want that direct personalized engagement which this tearcheck unit can provide for you, which then you can in turn help the patient achieve that understanding and believe that, okay, for me, I see this is my problem, therefore I need to do X, Y, and Z. Let's go to the next slide, please. So now we're going to go to the treatment modality. Obviously, once you diagnose and educate the patient, next comes treatment. Treatment, again, it's in two arms. One is the in-office part, because patients are notoriously non-compliant, even though they have the best of intentions. When they leave the office, they're gung-ho. You know, a few months in, a few weeks in, and we know bad habits creep in. They forget to take their oral supplements, do their lid scrubs, etc. So there is an in-office component that's really important. That's to kind of jumpstart the entire treatment and to truly fight the inflammation that is often the culprit with ocular surface disease. Let's go to the next slide, please. So these are the treatment solutions by IMED. Next slide. This is what the EI looks like, and it's for IRPL. I'm sure all of you have heard of IPL, intense pulse light, but there's an R, a capital R, in between the I and the PL. And the R stands for regulated. So how is IRPL different from IPL? Well, it's a very sophisticated formula for each kind of firing that you do of one light. There are multiple other bursts that happen that you're not even aware of and the patient isn't even aware of. But as a result, it's like a pyramid. One equals many. And consequently, this procedure is very fast and you need a lot less firing shots compared to other available IPL, traditional IPL technologies. It's compact, and you can see it again can sit on a desktop. It has a great carrying case with wheels and a handle. So if you have a second office, a satellite office, you can very easily transport it and put it in the trunk or the back seat of your car. Next slide, please. This is again what it looks like, and it's very, very quick. It's long-lasting effects, and IMED has quite a number of peer-reviewed publications, which IMED folks will be more than happy to share with you or provide a link for you that you can go and read at your leisure. And how does IRPL work? It actually closes off the abnormal blood vessels that leak pro-inflammatory mediators by taking away the bad guys, so to speak, and concurrently optimizing the surface, helping the meibomian glands get healthier, enhancing the lipid layer in the tear film. You're going to have the decrease of inflammation and the improvement in the tear film stability. And that kind of scale is what the patients are going to feel and notice an improvement in their eye symptoms. Next slide, please. So these are the steps, and I want to take a moment to go over them with you in case A, you currently do IPL the available way, and how it's different using the IRPL from IMED, or perhaps you've never done IPL and you don't quite know what the steps are, so I'm going to walk you through it. With this IRPL, it takes about 5 minutes to perform this cash pay procedure. No insurance pays for this. So the patient is educated and they have to do a questionnaire so you can kind of assess their Fitzpatrick skin scale. All of it is based on skin tone, and it asks questions like how easily do you burn, do you tan, questions like that. The patient has to sign a consent, and IMED will provide that for you or help you create one. And then we use kind of a wipe. You could use the IMED wipes that have, hyaluronic acid in it, or any other kind of wipes that you have in the office. And we wipe all makeup, grease, any debris off kind of the cheek area, temples all the way to the cheekbone area. Then we put the occluders in place. These are reusable and cleanable. And then we put a lot of gel, and this is the gel that we use for ultrasound, B scans, and so forth. It has to be the clear gel, not one that's tinted blue. And you have to apply a generous amount, as you can see in picture number 5. Based on the Fitzpatrick skin scale, you enter it, or the technician enters it into the IRPL machine, and it automatically sets the power. You don't have to adjust it at all. It's auto done for you. And then it guides you through step by step. Do this, it walks you through. It's very intuitive. And even if you've only seen one, you'll be able to follow all the steps based on this AI kind of direction for you. And then you, as the person performing the IRPL, have to put the special goggles on that are provided for you from IMED. And then you hold it, and you can hold it in one hand, you can alternate hands, that's up to the eye practitioner. And you start temporally, and you do 5 shots with minimal overlap, like you can see in picture number 10, and you stop by the kind of edge of the nose, and then you do the same thing on the other side. 5 different blasts, and that's it, you're done. And then you wipe the gel off. You don't have to do a second pass, you don't have to go above or below the eyelid. Therefore, it only takes about 5 minutes. Next slide, please. The treatment protocol is also that one treatment alone does not do the job. It can't. So a conversation has to happen with a patient from the beginning that it's a series of 3 to 4. I do 4 because I'd rather achieve what I'm trying to achieve. So I always tell my patients we're going to do 4. And these are suggested timelines. We do it. Treatment 1, treatment 2 is about 2 weeks later, then about a month later is treatment 3, and about a month later is treatment 4. Does it have to be exactly on that specific day? Absolutely not, because you could be at an ophthalmology or optometry meeting. The patient may be on vacation or may be sick or something. So plus or minus a few days is perfectly okay. The effect is cumulative. And actually, I tell my patients they're not going to notice a huge difference till after treatment number 3. You have to let them know that so they don't become discouraged. Next slide, please. And there's no downtime after the treatment. They can go about doing any of the activities except going sunbathing. They cannot go to Acapulco and lie by the pool. This IRPL is proven to be very efficacious. Many patients, 96%, would recommend the treatment, and you can see the high rankings that it gets. Patients confirm improvement of symptoms almost 93% of the time, and that's huge in our patients who have dry eye symptoms. And many patients, in this case, 55% of patients, stopped some of the other dry eye related treatments that they were doing because their eyes felt so much better. Next slide, please. These are some of the peer-reviewed journals. Again, if you're interested, IMED will make them available for you. Many of the studies were done in Europe, as you can see, Japan, Italy, New Zealand, Spain, and so forth. You may let's go to the next slide. So there are hundreds of, tens of thousands of these procedures performed worldwide. It's just new to the US. And now you've treated them in the office and you're going to send them home. And obviously they need to do follow-up care at home. It's almost like the deep clean at the hygienist. Just because you have it done, it doesn't mean you forego brushing and flossing and rinsing your mouth. You have to do all those things daily and then come back for that deep clean, once a year or thereabouts. With IMED, the recommendation for the IRPL is once a year, approximately. Again, it depends on the severity of the disease at hand. So now what are you going to send the patient home with? What's the home management therapy look like? There are ocular hygiene products, there's a dry eye ointment, there are oral nutraceuticals, and there are additional kind of heated mask options. So let's delve into those options. If we can go to the next slide, please. These are compounds and products that you will become familiar with. You don't have to memorize them from day one. It might seem, oh my gosh, it's so overwhelming. There are so many products. But actually, when you stop and think about it, it's only 3 for ocular hygiene. So let's figure out how each one differs from the other. Next slide, please. So I hope you have some questions for me. Start sending them in as I go through these various products. Any questions?
Dr. Matossian, I just wanted to mention to them that if you do have questions, you'll have to hit the Show Control Panel button, and then you can submit through the questions there. Thank you.
Michelle, do you want to repeat that again for our participants?
Yes. So if you have questions, you'll want to hit the Show Control Panel button on your screen, and then you'll see that there's an option to submit your questions.
Perfect. And then Michelle is going to kind of ask me those questions as they come in. And then, as I said, I'll do my best to answer them. The first product is eyelid and lash, and it's color coded. So if you don't remember the name, the yellow one is the one that has hyaluronic acid in it. So it's a jar, you open the jar, and inside there are those round, thin, kind of cotton lid wipe type towelettes, for a lack of a better word. They're the circular ones. They are paraben free. They contain hyaluronic acid, and they do remove makeup. They do remove mascara as long as the mascara is not waterproof. If it's regular mascara, this product will get it off. If the patient wears waterproof mascara, you may want to kind of talk to them about it. And ideally, we know waterproof mascara is not very good for the eyes, not very good for somebody who has dry eye disease. So they should ideally change to a water-based mascara, which then can be removed with this yellow striped product with hyaluronic acid. The hyaluronic acid also leaves the eyelids very nicely moisturized. And the key is, don't wash it off. Once you wipe your face, your eyes, your periocular area, your cheeks, don't wipe it off. Leave it on there, and the hyaluronic acid does its magic. Next slide, please.
I have some questions.
Sure.
The first one is there a decrease in wrinkles? And I'm not sure if that question had to do with the EI or if it has to do with the hyaluronic acid products.
Well, I'll try to answer it for both. With the EI, the IRPL, rosacea patients, especially patients with rosacea, notice an improvement in hyperemia around their eyes and rosacea blepharitis after an IRPL treatment. But I never promised decreased like lines, aging lines, because I'm not like a cosmetic surgeon. I don't claim to have much knowledge about aesthetics. So I just say my area is ophthalmology. I'm sticking to that. I know your rosacea blepharitis will get better with the IRPL. With a hyaluronic acid, clearly it plumps up like some of the dehydrated skin cells. But again, I don't purport to be a dermatologist, a plastic surgeon. So I just say it's going to moisturize your periocular area. I just leave it at that. I try not to like delve into areas where I am not the expert.
I have another question.
Sure.
Thank you. With the IRPL device, are there any tolerance or safety issues?
Because it's very auto-calculated, meaning that based on the Fitzpatrick skin scale, 1 through 4, you enter the data into the machine. It won't let you start without that information in it. It automatically sets the power settings. It's so safe. As I said, tens of thousands of these procedures have been done. Hundreds of thousands of these procedures have been done worldwide. And if you follow all the rules, apply a generous level of the gel, and because of that proprietary R for regulated way, it shoots the beam with this multiple kind of ripple effect. Burns are nearly, I mean, almost uncommon. I never want to say never because I don't know of any reported cases of burns, but again, we never say never in medicine, but it's inordinately safe.
The other one is so there has been no adverse events reported to Dr. Matossian's point. Another question, are you expressing glands after the IRPL treatments?
That's always a very, very good question. Many of these studies that we referenced in 1 or 2 slides earlier were done and actually where no expression was performed, meaning the patients went through IRPL, they had pre and post treatment, primary and secondary endpoints that were evaluated, and the endpoints improved post treatment without expression. However, if you want the patient to kind of get a jump start and to start feeling better sooner, immediately after the IRPL, where the glands are warm and the meibum is somewhat liquefied, by doing manual expression, especially of the lower glands, it will make a difference, and the patients may start to feel symptomatic relief sooner. It's again up to you if you want to do it or not, but the patients may get symptomatic relief faster and sooner if you do manual expression. Some people may do the manual expression after the second, maybe the first and second treatments, whereas after the third and fourth may just do the IRPL and not do the manual. A lot of it also depends on what their meibography looks like, how congested the meibomian glands are, how much inspission there is in the glands. And that's a decision left up to the eye care provider.
Great.
So now we'll go to the next slide. And that's a jar that looks similar, but notice the color of the band is different. This is kind of, moss green or sage green. And this has tea tree oil in it. So it still has the hyaluronic acid. It still has all the other ingredients as the one with the yellow band, but it has the word plus in its description. It's eyelid and lash plus because it has the 5% tea tree oil. Now, 5% is not as high as some of the other compounds or products that are out there, but it's not so little that it barely makes a difference. 5% is just that right magic number where it might sting a tiny little bit, but it helps with demodex. It helps with kind of more persistent blepharitis. So the tea tree oil as an anti-infective can also help clear up some kind of mask-related acne on the cheeks and the face. So some people use this one, the tea tree oil one, on their face, but use the hyaluronic one around their eyes if they don't have Demodex issues. So you can mix and match depending on what's happening with the eyelid margins and your skin on your cheeks and face. The next product is this one called Eyelid and Lash, and it's Hypochlorous Cleansing Spray. This is a spray that you can actually mist across your face with your eyes closed on your face. And it's almost like peanut butter and jelly, brushing and flossing. This is where you do the wipe. The wipe is the mechanical friction that removes any built up biofilm on the lid margin, any perhaps collarettes at the base of the lashes, any micropollutants or makeup debris. And then the hypochlorous acid is a natural anti-infective. So this is like a 1-2. You need both. And I use this a lot. I have a little one in my purse. This is 120 mLs. It lasts a long time. And you know, I do it in airplanes. As soon as I get on the airplane, I do it. I do it like middle of the flight because I don't want anything to like get around my mask while I have the mask on. I do it over my mask. I even spray it on my hands. It works on so many different surfaces. It's not just meant for the eyes or face. It's very gentle, no stinging, no burning. And once you open it, because it is a very stable formulation of hypochlorous acid, it's effective for 3 months. It does not go bad after 30 days. So one bottle like this will last 90 days. Next slide.
Dr. Matossian, I have a great question at a good time. So what is the best treatment for chalazion or hordeolum?
You know, we are at an epidemic with hordeola and chalazia. Some of it is from mask wear. Some of it is from that upward movement or pushing of the air from our oral cavity, from our nares and nostrils directly up to our eyes and ocular surface, where instead of going out, it's going straight up and hitting our ocular structures. Sometimes it's the riding up of the mask towards the meibomian glands, like lid margin, and putting pressure there and kind of that altering the amount of pressure on the meibomian glands, leading to some congestion. So with that said, we are seeing hordeolum, chalazia, hordeola so often. I probably see multiple a day, every day in the office. So how do we treat it? Number one, you need your tearcheck diagnostic device to see what is the lipid layer like. What is their meibum looking like? What's their meibum height, their meniscus, tear meniscus height? What is their meibography? Often they need oral supplements of the omega-3, so it's a perfect segue for that. Because if they have 30, 40, 50% or greater loss of their meibomian glands, which this diagnostic device will tell you and tell the patient, then clearly they don't have enough meibomian glands to make enough meibum or lipid oil, or the quality of the oil is so poor that it's just not holding the aqueous back. So it's viscous, it's staying in the glands, it's not flowing, and therefore becoming infected. So the way I treat it is, again, educate the patient after you make the diagnosis. Put them on oral omega-3 supplements, a good quality one, like a re-esterified triglyceride form of oral omega-3. Use a heated moisture mask to keep the meibum as liquid as possible. The IRPL really works well for chalazia and hordeola because it is, like we talked about, closing off the abnormal vessels, killing off the pro-inflammatory mediators, and I zap the chalazion 3 extra times or 2 extra times with the light of the handheld device, and that really helps kind of dissolve it. Does it make every chalazion go away? Absolutely not. Sometimes they're going to need an antibiotic steroid ointment or a solution like antibiotic steroid combo. Sometimes they're going to need an intralesional steroid injection, or sometimes they're going to need an IND. But at least in some cases, you're able to treat them without an incisional approach. Next slide. Oral omega-3s, I'm a big believer in them. I personally have been taking them for about 15 years. My husband, my mom, who's 97, takes them. We all take them. It's a family affair. Because I know that just like my glands on my skin are not making as much oil as when I was 16, 14, 15 years old. Instead, I'm applying moisturizer on my face. The same is true for the lipid-producing glands in our eyelids. They're just not making as much lipid, my bone. So we need to help by importing or swallowing oral omega-3s in order to boost and help our meibomian glands make better quality and have ample supply of that lipid to prevent that evaporation of the second or aqueous layer of our tears. Because the iView omega-3 plus from iMed is a very concentrated formula, and they have EPA, DHA, and DPA combo, you only need 2 capsules, and it comes in a big jar of 60, and it is the re-esterified or the little RTG formula, which is much more bioavailable for your gut flora. Meaning that when you swallow this, and always take it with food, I tell my patients always with food, and a cup of coffee is not food. It really makes a big difference in the absorption percentage. With this, the absorption is close to 80–85%, whereas with the other formulations that are cheaper and available at, let's say, large stores, you're only going to get about 23–24% absorption. So you might think, okay, I'm taking the same milligram capsule. Yes, you're swallowing that, but only 1/4 versus 80% is getting absorbed with the ethyl ester or EE formula versus the RTG or re-esterified triglyceride formula. And because of its faster absorption, you rarely get the kind of nasty fish burp that people complain about or fish gas, because if the absorption isn't there, it's not quick, and the fish oil just sloshes around your intestines and stomach, that's when people talk about GI upset and the fish burp. By the faster absorption, you're kind of eliminating or decreasing the risk of that. And 2 capsules is not too many to swallow. Most people can handle that. And I say you can take both at the same time as long as you're doing it with food. And we can go to the next slide. And please continue, sending in your questions. I'm here to help you figure out and better understand iMed, tearcheck, the different at-home products, as well as the IRPL.
I do have another one, Dr. Matossian, and it's back to the IRPL. Does the IRPL destroy the Demodex mites?
I don't know of a specific study with the iMed, IRPL, and the specific demonstration of death to mites. But with regular IPL, I know for sure it kills Demodex mites instantly. They just kind of, seize up and die, and movement immediately stops. So I'm going to hypothesize, and please experts from IMED who are here as my supporters help me answer this question. Are there specific studies that IMED has done where you've looked at the effect of IRPL on Demodex death? Blair, do you know of any such studies, or Brent?
Hi, Dr. Matossian, it's Blair McEwen from IMED. So no, like you mentioned, there is no specific study with the EI device, but as you say, the technology, IPL technology and IRPL technology, very similar in how they act, but very unique in how the methodology is working, but the base principle is the same. So we haven't done any specific studies, but you know, all indications point that there is potential benefit there, but we haven't done specific studies.
Thank you for that. And I do use it in my patients who have Demodex by looking at the collarettes, and I have noticed improvement in the number of collarettes, the concentration of collarettes, the kind of redness, that hyperemia that patients get with Demodex right at the base of the lashes. So we'll have to do that study. And if any of you is interested in doing maybe an investigator-initiated study, please contact the folks at IMED, and maybe you and IMED can do that study together, and we'll have our answer. The next thing I'm going to talk about is dry eye ointment. Most patients don't like putting ointment in. They struggle putting it in, you know, they don't know how much to put in, and then they say, I can't see a thing. And of course, you don't want them to be a fall risk, or, you know, and many patients put stuff in their eyes while they're in bed, and then maybe they read for a little bit before they fall asleep or watch TV. But clearly, you cannot do that with a dry eye ointment. However, there's a really important role with dry eye ointments in our more severe dry eye patients. These are patients who perhaps have lag ophthalmos. Maybe they've had Bell's palsy and their upper and lower lids don't oppose properly. Maybe they have nocturnal lag ophthalmos, where the two lids don't come together perfectly while they're sleeping. They're completely unaware of it. So they're kind of a strip. Usually it's the lower 1/3 of their cornea and conj lights up with fluorescein and lissamine green. It could also be our patients who use CPAP or other nasal mask therapy devices, because there's some retrograde airflow that kind of escapes no matter how tight or how good that mask fit is. And of course, where is it going? Directly up to the eye. So it's like sleeping in front of a fan all night. For these patients, I definitely recommend a dry eye ointment. Let's go to the next slide. IMED is Eye Defense, and you can see a picture of it here. It comes in a tube, and it too has hyaluronic acid in it. So it will moisturize and create that barrier from CPAP mask, or let's say that lag ophthalmos patient, that patient who maybe had very aggressive blepharoplasty where their eyelids aren't meeting. So it has a place, but it's not for every patient. And you have to warn the patients that once you put this in, you truly have to close your eyes and go to sleep. You cannot watch TV, read a book, you know, but then the patients say, what about a few hours later when I have to get up to use the restroom? By then, enough of it has melted that you will be able to navigate to the bathroom and back, but a layer still stays on the cornea and conjunctival surfaces to prevent that dehydration or evaporation of the tear film. Next slide.
Dr.
Yes.
We're at 10 minutes, and I know you're wrapping it up here, so you're doing well with time.
Well, thank you. I always appreciate that heads up because I'm not looking at a clock as I'm talking to all of you. So this is where the eye relief comes in. Let's go to the next slide, please. The eye relief is a mask that you can do two things with. You can heat in the microwave for 20 seconds, or you can put it in the freezer for 30 minutes. So it can be used for headaches, for allergies, for migraines in the frozen state, or you can use it in the moisturized heated state for MGD and dry eye disease. And that little blue kind of shadow behind the eye relief is what IMED calls the slip cover. You can put the actual mask inside that slip cover and then put it over the eyes, then take the slip cover off and wash it. So the mask doesn't get so dirty because you're washing the slip cover, so to speak. It has beads in it, which then heat or cool and maintain that temperature. Next slide, please. And lastly, this is almost the last slide. IMED has made it easy for you, and they've kind of compartmentalized or packaged things for you. There's the Demodex one. That, of course, has the hypochlorous acid spray, the lid wipes with the tea tree oil, of course, the omega-3 oral supplements, and a mask, either hot or cold. Of course, for blepharitis, you probably want to do the hot one. Then there's another kind of siloed package. It's the MGD one, where it's the same hypochlorous acid, the same omega-3, the same mask. However, it's the lid wipe with just the hyaluronic acid without the tea tree oil. And the ointment can be purchased separately because not every patient needs the ointment. Next slide, please. And with that, this is almost the last slide. With IMED Pharma, you have all of it under one umbrella. You don't have to go to different companies, different products to achieve what you want to achieve. You can diagnose using the tearcheck and looking at all the 9 different factors. You get your report card, share it with the patient, and then monitor treatment progress. And hopefully you're going to go from the red to the yellow to the green with treatment over time. You're going to treat in the office with the EI or IRPL, and then you're going to send the patient home with the appropriate at-home remedies. Next slide, please. So with that, if you're interested, there are names here with email addresses and phone numbers. Brent, Michelle, Lynn, all of them would be more than happy to speak with you. You can email them, text them, any questions that you have that come to mind. You can always reach me, and I'm more than happy to help you. So I hope I've answered many of your questions, and I hope I've made that. Where do I start with treating dry eye? How do I start? I hope I've answered that question, because the answer is with IMED, all in one, from diagnostics to in-office treatment to at-home remedies. Thank you very much.
We had one last question before we wrap it up that I think is a great one to wrap it up with, and that is, what is one technology that you could not live without in the world of dry eye?
You know, it's like saying, what's my favorite, food?
Exactly.
Or people say, what's your favorite wine? Because I study wines. It depends on what the patient is presenting with. I would say what we lack most is diagnostics. It is a science. Dry eye disease, as I started out the program, is a disease, and IMED has the tearcheck with a definitive diagnostics in it. Based on what's lighting up red or comes up in the red column, then you can decide which way to treat, which combination of treatments to use to deliver the best possible option for the patient. There is no shortage of dry eye patients. They are everywhere. They are already in your practices. They are already in your exam room chairs. They're desperate they're shopping, they're gypsies, they're going from doctor to doctor to doctor to find relief. And if you have something like this, you're going to convince them that you are an expert, you want to do the best for them, and you have demonstrated to them your commitment in this space by having an IRPL and the tearcheck device.
Thank you.